joining us today, uh, especially spending your lunch hour with us to get prepared for this season. And you're right, it's the season for sneezing. So sorry for the bad dad joke, but this is what we really want to focus on today. And I'm really excited to be joined by two amazing partners, Don Nims, who is our respiratory epidemiologist, and Dr. Lin, who is a professor and hospital epidemiologist at Rush University Medical Center. For those who don't know me, I'm Arti Barnes, the Chief Medical Officer at IDPH. Also, please note that this session will be recorded. And for those who are interested in CME, good news is we do offer CME. For those for whom CME may not apply, please check with your licensing organization whether this credit really can translate into credit for you. More good news, there are no conflicts of interest with any of our presenters or organizers today. And a little bit of housekeeping, we will get into our content first, save our questions, Q&A for the last. So please use the Q&A box at the bottom right hand of the screen, and we will get to it either live or answer the questions in the Q&A, depending on the volume of questions we receive. Please note that there is a post-webinar survey that will be available for about 7 days after the survey to get CME credit. Some of the CME questions are included in that survey, so please make sure you complete that in order to be able to receive those. Now, I'm going to start by actually going into the nuances of state and federal guidance for seasonal respiratory vaccines this season and what the practice implications are for all of us, especially around shared clinical decision making, and provide a few important tools on decision making tools for both testing, treatment, and preparedness. Now, Dawn is going to then delve into some of the new reporting guidance and what our expectations are for reporting respiratory illness this season. And finally, Dr. Lin is going to do a deeper dive into our updated infection prevention guidance for healthcare workers as well as for the community. And with that, I'm going to talk about what to expect this season. So the good news is the CDC does have a forecasting tool that tries to predict what will happen each respiratory season. And the good news is because we had a fairly moderate COVID season last fall, and so we either expect the same to slightly higher this season. Flu, because we had a very intense flu season last fall, we're going to expect a lower flu season and about the same for RSV. So we also have a seasonal respiratory dashboard, and that will hone in on where to look for information on what's really going on as the season evolves. As we're already just started the season, as it evolves, please take a look at the seasonal respiratory illness dashboard. It gives you Illinois information. Now, we were deriving information from CDC, and with the government shutdown, unfortunately, the main metric for all of Illinois was on pause. And thanks to Don and Mallory and some of our great epidemiologists at IDPH and a Herculean lift within 1 week, we now have an analog for Illinois that is similar to the CDC metric, and we're able to get our communities, our residents, updated information on what's happening with respiratory illness in Illinois. And you can see, thankfully, as of last week, this data is going to be about 1 week behind. We were still overall, for all respiratory virus levels, pretty low. What you'll also see is that we do a deep dive into the big three, flu, COVID, RSV, and tell you what's going on with that so you can make some informed decisions and especially informed conversations with your patients on vaccinations, protections, mitigations, and at your healthcare facilities too. If you do want to hone in to what's happening more in your region keep exploring this, go nuts, explore our respiratory dashboard. There's a lot of excellent information on there, including regional information. And you can see that there is, you can look by the big three as well as just overall respiratory illness activity. And I just picked, for example, Champaign here. You can see, are you trending up? Are you trending down? If you wanted to look, hone in at the county level, CDC did have, I should say, does have a great respiratory data channel that told you, gave you information on the big three: flu, COVID, RSV, for your county. That is unfortunately on hold right now while we are in the middle of the shutdown. So your proxy is really to look at some of the regional data that's available through IDPH if you are looking for granular information of what's happening in your community. And so the good thing is we can know where to find information, but what do you do with that information as this season revs up? It's important to know that vaccines are our most powerful tool, but only if people get them. And this is just a glimpse of what happened last fall. It was pretty disappointing to see only about 12% of our population really got COVID vaccine. Thankfully, about 30% got the flu shot. About, again, for the most vulnerable young children who are at risk for flu, that was closer to like 30%, about 30%, and about, again, over 30% got the RSV immunization coverage. And the question is why? And we're hoping it's not access that matters. So at least to address the access issue for publicly funded vaccines, we do have a vaccine locator dashboard. People can tap into it. These vaccines are procured through the Vaccines for Children's program, again, a federal program, as well as the 317 program that shouldn't invoke any cost sharing for those, for either the children or the adults that qualify for this. Now, the confusion really lies with who should get vaccines this season. Now, thankfully for flu and for RSV, there's less discordance, less ambiguity. But for COVID, as we've all experienced over the last few months, there has been significant change in the federal and national guidance that I'm going to unpack over the next few slides. And this is the brand new CDC's immunization schedule. And you can see COVID now, this is for children, it's nice and blue. And so the two big groups under consideration were really, what do we do about the children? What do we do for pregnancy? And this is the immunization schedule for pregnancy. Again, nice blue C notes. What is C notes? If you hone in down in the blue, it's about vaccination is based on shared clinical decision making. What does that mean? I'm hoping by the end of this talk that everyone attending has a good sense of how to have that conversation and what is the risk we're really trying to impart to our patients and our communities around whether they should get this or not. And so honing in just on the variants, both federal and national variants around COVID vaccine. This is something to just clarify that, because your patients and providers have been extremely confused. There's the FDA guidance that really guides whether someone's going to do something off-label or not. There is ACIP and therefore CDC's guidance that guides a lot of insurance coverage. And of course, there's the medical professional society guidance that's really focused on who are the at-risk populations. So to clarify, the FDA still, as of this point, says that children over 6 months and older can get the COVID vaccine as long as they have at least one risk factor. Now, they point to CDC's risk factors. Those have not changed. Pregnant people fall in that CDC risk factor. So while they haven't been called out specifically, they still fall under a high risk factor per CDC and therefore per FDA. For those above the age of 65, it was a slam dunk. All of the ones over the age of 65 and older should receive it. The ones who are adults who are younger should receive it if they have a risk factor. Now, ACIP said anyone over the age of 6 months can get it as long as there's a shared clinical decision-making model. and that risk plays into into this conversation based on that shared clinical decision. The higher, the more risk factors you have, then there's a stronger sort of push to consider those people for vaccinations. Medical Society, so AAP, for children honed in pretty granularly, said there is a group that is exquisitely vulnerable even to COVID, even during this endemic era, and those are the children who are under the age of 2 years. These children need vaccine regardless of underlying risk factors. They also said there are children that require or should get vaccine, not require, I should say, but should be recommended for vaccine. And those are children who do have underlying risk factors, who are older, or they live in high risk settings, congregate settings. They've never ever been vaccinated for COVID, or they are trying to protect someone in their household. Maybe they live with a family member who is on chemotherapy, cannot mount a good vaccine response, and then it's worthy to have that discussion with the child to make sure that they are have the ability to protect those around them too. And of course, if you have a parent who really says, I do want my child to have this protection, they should be warranted that protection. And so for pregnant people, the American College of Obstetrics and Gynecology was aligned that they should get a vaccine unequivocally, including in the postpartum and breastfeeding states. And of course, AAFP said all adults should get the COVID vaccine. So to really find some homogeneity and make it simple for our providers, for our residents, what Illinois did is our Illinois Immunization Advisory Committee really met in September to hone in, to simplify these recommendations, to clarify these recommendations, and to take an ultimate position on them. And after doing so, submitted those recommendations to us at IDPH, and we adopted those within 24 hours. And try to come up also with good communication tools. Now, this is a one-pager that explains our position on flu, RSV, and COVID. This is not going into what type of vaccine, who gets a higher dose, lower dose of vaccine, and additional doses. This is really a very simplified model for who should get the vaccine. This also is not really honing in on, immunosuppressed groups or any for additional doses, etc. So for children, for flu, yes, children above the age of 6 months should get their flu shot. Pregnant people for sure should get the flu shot. Adults should get the flu shot. For RSV, again, no discordance here. For those who may not be aware, there is a new monoclonal available for infants this season, which is clesrovimab. And so infants under the age of 8 months whose mothers did not receive the RSV vaccine during pregnancy should get the monoclonal, whether it's nirsevimab or clesrovimab. And children between 8 and 19 months should get the monoclonal if they're at increased risk for RSV. Now, pregnant people between gestational age of 32 to 36 weeks should get it. And the reason this gestational window is narrow is to avoid any risk of preterm, but after multiple population-based studies, and it seems like it's still fairly safe to get it at this gestational age, and no real threat. Additional safety signal threats have emerged as far as pregnant people if they get it within this 30 to 36 week window. And adults who are at risk of RSV between 50 to 74 should get it, the vaccine, and everyone above the age of 75. Now, this RSV vaccine, it's important to know it's a one and done vaccine. If you got it at a previous season, you don't get it again. I'm talking about the vaccine, not the monoclonal. It's a one and done. COVID is where a lot of, I think, the confusion needed clarity. And so for us in Illinois, we are aligning with the fact that children under the age of 2 should get the COVID vaccine. So we are aligning with AAP, and the children who are slightly older who have risk factors or are in situations at risk, again, and of course, if their parents want it, they should be able to get the vaccine. For people who are pregnant, during pregnancy or in the immediate postpartum state should also receive the vaccine. And this is important. I'm going to go into why over the next few slides, and why it's important that we understand the risks so we can communicate those risks very clearly to our patients. And again, everyone over the age of 18 and older. So to ensure that this guidance had some ability to be applied in a practical manner, we did issue a statewide standing order specific to COVID vaccine. It's over 13 pages long. It has all the details of the different doses, dose range, etc., multiple considerations. What the standing order does not do is change scope of practice. So we've gotten questions, oh, can my MA give the COVID vaccine under standing order? Well, it will still fall under the Physicians Medical Practice Act authority for any delegation. So with this standing order, in no way changes scope of practice. It only allows for when your scope of practice allows you to be delegated by a physician standing order to be to apply. Now, this is also part of this big umbrella, all of government approach. You may have noticed the executive order that Governor Pritzker issued saying all of government, all the state agencies need to come together and figure out vaccine guidance, vaccine access, and vaccine coverage. And this is just an initial piece of that great initiative, which is going to be the statewide vaccine initiative in Illinois. So one thing to hone in on, I'm just giving a couple of screenshots from our standing order, is what is at risk? Now for COVID, for flu and RSV, we might have it's a shorter list. COVID has a pretty long list, and some of these factors go under the radar. And I have to say, we've had a lot of calls from constituents who said, I have obesity. I went to the pharmacy and they said I shouldn't get it. They wouldn't get me the COVID vaccine. A pregnant woman went to a pharmacy and they refused to vaccinate her. She had to find another retail pharmacy where she could get vaccinated. So I think the hope is that we educate ourselves about what really constitutes risk. And a couple of things that go on the radar: physical inactivity. And I wanted to highlight that we put this in a format that providers will hopefully find easy to peruse relative to the CDC format. So it's easy for them to go through it and checklist if someone really does have an underlying risk factor, if that factors into their shared clinical decision making. Now, CDC went through pretty heavy evidence for each and every single one of these. So while you might say, oh, physical inactivity, why? What we picked out for the explanations, for even the definitions, are based on all the large meta-analyses and the trials that they reviewed and the definitions that were used in there to define physical inactivity. And so we're saying, go with any one of these, because often we overestimate how active we are. We are not a very active people. I would meet the definition of physically inactive based on this. And again, so this is available on our website. You could go search for the standing order. If you go to Appendix C, this is where the list is, if you feel like this format is easier for you to understand and digest. The other thing is mental health conditions often go under the radar. Neurological conditions are not always on in our thoughts in terms of those that qualify for a risk for COVID, and not just being obese, but also overweight. And so I think it's important to understand this plays into not just your decisions and your discussions around vaccination, but also in your decisions around treatment for COVID. So how did we get there? And this is an explanation of what drove us to recommend what we recommended, especially for making a non-risk-based decision for certain age groups. Now, when we looked at national data, unfortunately, even in the endemic era, we're talking about 2024, 2025, 40% of the hospitalizations for COVID were in that age group of children under 2 years of age. We looked at Illinois data and we found out that, again, it was mostly 60% were in the kids who were under 4 of the COVID hospitalizations, and most, 9 out of 10, had no recorded evidence of a vaccine. none. And so that's definitely concerning. So we looked again to see the trend, the percent of hospitalizations for COVID-19. This is just, again, we looked at our own data in Illinois in addition to national data. And the children under 2 had a higher percent of hospitalizations for COVID-19. And I'm talking about now in the last, this endemic era and this last season, than people who are over the age of 65, for which FDA has had a clear no risk recommendation for vaccination. And most of you may think, well, I'm sure these kids had underlying risk factors, right? They were sick. Well, not for the 6 to 23 months old. Majority, 54% of them, and this is national data, had no underlying risk factors. These were the kids who ended up hospitalized for COVID, had no underlying risk factors. Now, that's even higher, 70% for the babies, and that is the case for maternal vaccination. The only way these babies, most of whom had no underlying risk, could get protected is through maternal antibodies. And so again, and this is important to have an understanding of this when you have that discussion with your patients. Now, again, this matters. Children last season, 12 children in Illinois died of flu, 3 of COVID, 6 of RSV. So this is not something we should just say it's okay, 30% vaccination in these age groups is acceptable. I think as a clinical community, we can do a little better than that. And this is the final, just to punctuate the case for COVID vaccination in pregnancy. It's not just all pregnant women should consider that, especially if you serve populations where women get pregnant or there are large amount of pregnant people. Let them know that, children under the age of 6 months had a higher rate than, like a 3-month-old had a higher rate for COVID hospitalization. And I'm talking about now in 2025 than a 65-year-old. So when we think about respiratory seasons, we think, of course, the big 3, flu, COVID, RSV, but what else is lurking? And our respiratory dashboard will tell you a little bit of information on what the labs are seeing. And you can see what's really predominant is actually fairly mild for the most part, which is the common cold, enterovirus, rhinovirus. That's really what is always going to be sort of one of the most predominant. But this season, we are seeing a unique signal with hand, foot, and mouth. And this is non-polio enteroviruses, which we think is driving some of that lab signal that you're also seeing. So what does that mean for those who've had kids or been around kids? Hand, foot, mouth is no fun. Thankfully, it's fairly mild. Kids don't end up hospitalized as much with it. Sores in the mouth, rash on your palms and soles, fever. For really young babies, the rash can also be in the diaper area, and I think that's an important place to look. It is seasonal, but you can see on your right, the graph, we are having an unprecedented, really high hand, foot, mouth season. It's like higher than in the last 5 years. And good news is it's not more virulent, but de facto, we are going to see more enteroviral meningitis. We are going to see proportionately more hospitalizations, but it's not disproportionate to just to the volume of infections that we're seeing for hand, foot, mouth. And so when we think to final things on preparedness beyond vaccines, what's next? This is a tool from the Academy of Diagnostic and Lab Medicines that I found very helpful for the most part, to think through who needs testing. When do I only test for the big 3? And when do I really think about this kid needs a multiplex panel? I do suspect it. Of course, someone's got a rash like hand, foot, mouth. It's not measles. We get a lot of measles testing for kids with HFMD, but we have a measles decision-making clinical toolkit on our website too. But this one helps really think through, are you in an inpatient or outpatient setting? How symptomatic are you? How immunocompetent are you? To really go through an algorithm for targeted versus broader multiplex testing. And testing matters because treatment is effective. We do, unlike most viruses, we do have treatments for flu and COVID. And treatment for flu is even more time sensitive than COVID. You only have 48 hours. But one infection prevention aspect that's important to know is if you are in a residential facility, long-term care nursing home, long-term care facility, or inpatient ward, if you have an outbreak on that ward, you have to consider chemoprophylaxis with antivirals to the people who are exposed on the ward. So it's going beyond just treating the individual. And COVID treatment, as many may know, is based on those underlying risk factors. So it's important to educate yourself on what those underlying risk factors are, and make sure that that treatment is also time sensitive within 5 days. To the right, you will see that there is, one important tool as far as signage is, it's not just one sign for flu, one sign for COVID, one sign for RSV. It is now really an all flu, COVID, and RSV, a combined approach. And so hopefully, if you need to update your signage, there are updated signs and tools out there. And finally, before I turn it over to Dawn, is thinking about preparing for outbreaks, especially if you service congregate settings, whether it's inpatient wards or whether it is long-term care facilities. And couple of key things to think about it as you're entering respiratory season. Yes, you will have outbreaks in your facilities. How do you prepare for that? One, make sure the authority for your infection preventionist is codified and it is in policy, so it's very clear what their role is. Make sure that there's enough, all your patients have had the choice to get age-appropriate vaccination, that you are actively surveilling for acute respiratory illness in these settings, and that all the visitors and residents are educated about it. Staff are educated, and maybe this is just-in-time training before every respiratory season launches. Make sure that you have the ability to know who to test. We have seen outbreaks where it's been almost a week before we've had any diagnostic testing, even though people keep getting sent to hospital 911's call to nursing homes. They get transferred to the hospital, and yet we're like, what is the etiology? And it's taken a big delay in getting that testing. So make sure you have testing in place, especially if it means getting standing orders that are local to your facility to expedite testing and treatment in these situations. And with that, I am going to turn it over to Dawn and have her talk to us about what the expectations are and the new reporting and testing guidance from IDPH.
Hey, thank you, Dr. Barnes. Hello, I'm Dawn Nims, and I'm with the I'm a respiratory epidemiologist in the Illinois Department of Public Health CIDI program. And I'm going to review with you some of the respiratory conditions that are reportable to IDPH, how to report them, and then I'm going to review some respiratory testing guidance relating to when it's appropriate and how to submit respiratory specimen to our IDPH laboratory. So on this slide, we're going to start out with an overview as to what respiratory conditions are reportable to IDPH. So in regards to individual case reporting, flu, COVID, and RSV cases are reportable only if the person was admitted into the intensive care unit or ICU, or if there's a pediatric death in one of these conditions. And we'll review the case definitions in the upcoming slide. But these cases are reportable to IDPH via INED, which is our surveillance system, or if you're a provider, you should be reporting those to your local health department or submitting a provider report if you do have access to INEDs. Go ahead and report those in there. So under flu, we also have novel influenza as a reportable condition. So these are reported if there's suspicion for a novel flu strain, so which is a non-seasonal or regularly circulating strain, or if it's identified through testing, which is very rare and hopefully don't see any. But typically we already know when there's a possible exposure, these may be coming, or there's been exposure to a possible animal. As far as outbreaks are concerned, any acute respiratory infection or ARI outbreak in a congregate care facility is reportable to your local health department and then to IDPH from our local health department. This goes into our outbreak reporting system that the local health departments do. And then lastly, as of last season, laboratories are required to submit all positive results electronically for the 3 listed conditions here, flu, COVID, and RSV. Send them to us, IDPH, via electronic laboratory report, or ELR only. So it's always been like that for COVID, but we added flu and RSV last year. So also please note for COVID, this does not include point of care testing. Again, this is only mandated for labs that report electronically. So If you're a provider or local health department, please don't hand enter labs into our surveillance system. The only time you should be hand entering any case or lab is if it meets the definition of an ICU case, a pediatric death, or novel influenza. So now I'm going to do a little more in-depth on individual case reporting and definitions. So here you can see the respiratory ICU case definitions. A case is considered a reportable ICU case if the individual was admitted into the ICU and had a positive lab result for any of these 3 pathogens, regardless of the reason for the ICU admission. So we get that question a lot. They do not have to be in the ICU due to one of the conditions in order for them to be a case. This is for surveillance purposes, and we want to count all the cases regardless of admission reason or clinical symptoms, since we don't always know, how asymptomatic infections can occur with some underlying conditions, plus these diseases. And then if they were in the ICU, we want to track burden for the positive cases, not only during the season to see kind of when we're peaking, but also outside the season. For example, if we start seeing cases outside what our normal respiratory season is, we would expect, that might raise some red flags to us, and we do some further investigation. So as far as classifying per the case definition of confirmed or probable, that's typically done at the local health department level. So if you're a provider, you don't need to focus on that. Just make sure you're reporting into INES or your local health department, and then the local health department will finalize that and investigation and classify the status. Just to note on these, at-home tests do not count for identifying a positive flu or COVID, positive COVID or flu patient. So we only want those cases reported when testing was conducted in the laboratory or a point of care test was done, like at a long-term care facility. Okay, next slide. This is just a quick slide with some information. We get asked a lot, what is your absolute minimal need to know information for these cases? And so we wanted to put it on the slide here. For those of you not familiar, this is a screenshot of our surveillance system, INEDS. This is our ICU module. So for these, the ICU question must be answered yes, with a date the patient was admitted into the ICU. We also ask for complete laboratory testing information, since that's important to determine if it's a case in the case status, or if it even should be considered a case. So this is an example of an influenza case. Notice that for these, there are additional questions for the type and subtype results, along with some specific testing information. This is very important to include if you have it for flu, because if you don't, additional testing may be warranted, which we'll discuss in the upcoming slides. But many times these labs are reported via electronic laboratory reporting. So you have the lab in there already, you just pull it in and then pop in those extra questions for the type and subtype. Providers, if you include this information in the case reports to your local health department or into INEDS from the beginning, this will save you and the local health departments a lot of time from having to kind of call you up again and bother you, because we know you have important work to do for any missing additional details that are mandatory for these cases. So we just wanted to make sure we point this out. On the next slide has our pediatric death definition. As previously mentioned, pediatric deaths of all 3 respiratory pathogens, COVID, flu, and RSV, are also reportable conditions to IDPH. Each pediatric death definition is the same, which requires a positive disease-specific lab and a disease-specific or equivalent cause of death listed on their death certificate. There should also not be a period of complete recovery between the illness and the death in order for us to count it as a pediatric death. And then our last reportable individual condition is novel influenza. In the last calendar year, we saw an increase in H5N1 activity in wild birds, poultry, cattle, other animals, as well as several human cases throughout the country. So local, state, and federal health groups, we continue to partner together and monitor H5 activity. And thus far, knock on wood, Illinois has not seen any H5 human cases, and we actually haven't had a novel influenza case reported to us since 2013. So that's a good thing. So, but facilities should notify the local health departments when you get a flu specimen that's unsubtypable, so further testing at IDPH can be done. Specimens can also be sent to the public health lab if you have a suspicion of novel influenza, which again, we'll discuss on the upcoming slides. So next, we're going to talk a little bit about the acute respiratory outbreak definition. So the acute respiratory or ARI outbreak definition will remain the same as last season, and it does include all acute respiratory diseases, not just COVID, flu, and RSV. So to kind of break this down a little bit, I know it gets kind of complicated. So we're looking at either symptoms or lab results, which can be used to count cases toward the outbreak threshold. The symptoms are based on the acute respiratory illness definition, which is characterized by any of the two following signs or symptoms that are new or worsening in the resident's normal state. So they're all listed there: fever, cough, runny nose, sore throat, et cetera. So to meet the definition of an outbreak for reporting to IDPH, the facility must have 3 or more residents and or staff in the facility with any combination of acute respiratory illness and or a positive point of care or laboratory confirmed test. And all of these should occur within 72 hours of one another. In addition, one of those cases must be a resident, and then the outbreak can be considered over once 14 days have passed with no new illness onset. So we want folks to remember that, you know, the 3-case outbreak definition is our surveillance definition and a threshold for reporting, you know, to IDPH in our outbreak reporting system. But every single case of respiratory disease in a congregate care facility should prompt an investigation to determine if others have been exposed, and timely testing and infection control is imperative, as Dr. Barnes mentioned. So additionally, some local health departments may request a smaller number of cases to be reported to them. So make sure you kind of work with your health departments on that. And then just to make sure to know, outbreaks in high-risk congregate care facilities include long-term care, assisted living, and others. Those are the outbreaks we want reported to the IDPH communicable disease section. So how do we report these outbreaks? So touched a little bit on the last slide with our outbreak reporting system, but facilities are to report outbreaks to their local health department, and many local health departments have, you know, preferred mechanisms in order to do this. Last season, we did develop an electronic outbreak reporting tool or form that replaced our old IDPH paper forms. So there's a link to this form available on the skilled nursing and long-term care guidance web pages, as well as on our public respiratory surveillance page. And this link allows facilities to report their outbreaks, upload line lists, and even has the functionality for you to kind of come back into the report and make any updates that you need. So the IDPH communicable disease, infection control staff, as well as the local health departments all have access to this project and those reports. So essentially, you're reporting it to both IDPH and your local health department at the same time. It's not mandatory to use. It's just an extra tool that we found useful and easy for entities to use for outbreak reporting. So once the facilities report these outbreaks, either via the electronic reporting link, which is through a red cap, or through any other mechanism to the local health department then puts that in our outbreak reporting system. Okay, I know we kind of moved on to the next slide. So for the next few slides, we're going to talk about when it's appropriate to request respiratory testing through the IDPH laboratory. So with the exception of laboratories enrolled in as our virologic respiratory sentinel sites, routine testing performed for independent and outpatient clinic care, including PCR testing, should be obtained at clinical and hospital laboratories internally. So when we want to send them to our lab, so for this current respiratory season, these are the only kind of criteria that meet the requirements to send it to our IDPH lab for testing. So the first one here are specimens that are approved by local health departments on a case-by-case basis, such as for outbreak management or virus identification in a congregate care facility, post-mortem evaluation, and cases suspected of novel influenza. Also, we will accept influenza specimens from individuals in the intensive care unit or ICU cases, which have tested positive for influenza A, but the specimen has not been subtyped by the facility. So we still want those submitted this season as we did for last. And then lastly, influenza specimens that cannot be subtyped. So for instance, if your lab performs a molecular assay and it's able to detect all currently circulating influenza A subtypes, but it results in unsubtypable, we want those sent to us so we can test them on our instrumentation. So in order to request this testing, if the criteria for testing at the IDPH lab is met, next slide. A facility or local health department can request the specimen to be sent to our IDPH laboratory. If a facility is requesting the test, this will need to be done through your local health department, not directly through IDPH. And then once the local health department receives that request and it meets the criteria, they'll fill out a form for us. And then once the IDPH respiratory team takes a look at it and it's approved, The lab or site can send it into our IDPH laboratory using the electronic test ordering and reporting portal, also known as eTour. So this is for testing through the influenza SARS multiplex testing that we do. So if your facility does not have an eTour account or access, you can reach out to the IDPH lab or the respiratory unit, and we can get you all set up. If you're requesting the respiratory panel, which typically we talk about that ahead of time and we know, but that is not done through eTour. That's actually through our old paper forms. But if and when the time comes, we'll work with you on getting those submitted. So lastly, I just wanted to include a slide that had some quick links to the resources and guidance materials discussed on the slides pertaining to respiratory pathogen reporting and specimen submission guidance. So we have the IDPH infectious respiratory webpage that has our surveillance page with our dashboard that Dr. Barnes showed you, novel influenza information, guidance for our congregate care facilities with our outbreak definitions. There are also links to our respiratory testing and reporting guidance memo that went out last month. So if you need that refresher there, there's a link. We have a link to the electronic reporting form, outbreak reporting form, a link to our Internet A to Z page with a bunch of information, not only on respiratory diseases, but a little bit of everything. And then lastly, we have the contact information to both the IDPH CD respiratory team and our public health laboratories there for you. So now I'm going to pass it over to Dr. Lynn.
Okay, hi everybody. I'm sorry, I'm having a hard time showing my camera, but I think you can hear me, so I'll just go ahead and get started. My section is going to be focused on isolation and masking recommendations to prevent respiratory virus transmission. And it basically answers the question of when someone gets sick, how long do they need to be at home and isolating, and what do they do when they come back into their work or other congregate or public setting. And I'll be focusing on mostly healthcare personnel, but also touch on community guidance, both of which have been updated over this past year. So for the outline of my talk, I'll first talk about why harmonize isolation recommendations. And by harmonizing, I'm talking about COVID, flu, and other undiagnosed respiratory viral conditions. Why have one recommendation for all the different types of viruses? Secondly, some of the science behind guidelines. Thirdly, what are the actual isolation and masking guidelines, both for the community and for healthcare personnel? Okay, so why harmonize isolation recommendations? Most people with upper respiratory infections do not get tested. And Dr. Barnes has already talked about the reasons why testing is important and why we want to report them, especially for treatment reasons. But in actuality, many people don't get tested. And the other part is many viruses that are non-flu and non-COVID don't have a test available, especially at home. However, CDC does have different recommendations for the different viruses. And for healthcare personnel guidance, for example, as of right now, official guidance is that influenza minimum isolation duration from work is 24 hours after resolution of fever. For COVID-19, it's really just a 10-day rule. And so there's some interest in harmonizing those particular guidances. And with widespread community immunity to COVID-19, it is appropriate now to harmonize COVID-19 guidelines with other respiratory viruses. So just talking a little bit about the science behind some of the guidance. So I'm showing you here influenza shedding and how it changes over time. And on the x-axis is the number of days from inoculation of healthy volunteers. On the y-axis, on the left side, you can see viral titers. And the dark line is viral shedding, at least the dark line with the dark circles. And so you can see that viral shedding peaks at 2 days after inoculation and then drops off rapidly. And that correlates somewhat with the total symptom score. This is actually the reason why a lot of the antiviral studies, when they were recruiting people for the trials, only recruited people within 48 hours of illness. And so you see that recommendation for antiviral treatment, which I do want to just emphasize that 48-hour rule is meant for community illness, but for patients who are hospitalized with severe influenza, antiviral treatment should be given at any point of hospitalization, even if it's beyond 48 hours of symptoms. SARS-CoV-2 has a slightly different type of shape when it comes to the infectious virus increase and decrease over time. So on the x-axis is time since onset of symptoms. This is not healthy volunteers, but looking at epidemiologic studies. And 0 on that x-axis is the time of symptom onset. And on the y-axis is viral load. So you can see that the viral load for SARS-CoV-2 actually goes up and is detectable even before symptoms appear. And it peaks right around day 0 at the time of symptom onset. And then it decreases thereafter. So my point is just that for both influenza and for SARS-CoV-2, the peak of the viral illness or the viral detection and viral shedding is either at or before the symptom onset. Now, how long are infected people contagious? So CDC published a review, this is in infection control and hospital epidemiology in this year, that summarized epidemiologic data that estimated the duration of contagiousness from symptom onset. The analysis incorporated estimates of incubation periods and serial intervals to arrive at estimated periods of contagiousness. And so what they did was there were a lot of studies that focused on households where there'd be a single person sick and then there would be secondary cases. And they looked at the distribution of those, the timing of those secondary cases to try to figure out how long was that first person actually contagious. Beyond household studies, there were also community studies, and they were all summarized in this review. And so the major findings are that the majority of transmissions occur early in illness by days 3 to 5 after symptom onset, with symptom onset being day 0. So I'm showing you now the specific data for influenza. There were 14 studies and 303 participants. By day 3, greater than 70% of all transmission occurred by day 3. And in fact, looking at the individual studies, the studies range from 71% to 95% of all transmissions being completed by day 3. And with a threshold of greater than 80% transmission, by day 5 was the time when greater than 80% of all secondary cases were transmitted. And that range was 86 to 100%. SARS-CoV-2 actually had a somewhat similar type of distribution. There were 21 studies, 15,000 participants. Looking at the threshold of greater than 70% all transmission, that occurred by day 3 in these studies. And the individual study ranges were from 71 to 97%. And looking at the threshold of greater than 80% transmission, that occurred by day 5 for SARS-CoV-2 with a range of 87 to 100% for individual studies. So these numbers do come into play later on when I show you the guidance. Because there is not much difference between day 3 and day 5 cutoffs in these studies, there's actually a lot of overlap. You'll see day 3 being used for the healthcare personnel guidance. And that comes from this summary table of those studies. But I encourage you, if you're interested, to go look up that particular study, the review from CDC. So what are the current CDC guidances for respiratory viruses? There's a community guidance that I'll go through in detail that was updated in August 2025. Now for healthcare personnel guidance, this is not yet released by CDC formally. And so what's happening right now is the healthcare guidance that I'm going to talk about was voted and approved by PHACT, which is an advisory committee to CDC pertaining to infection control practices. This was voted and approved by PHACT in November 2024. And normally after that vote, the guidance has to go to public comment period, and then another review by PHACT before submitting to CDC for adoption. So CDC has not formally adopted that CDC guidance, but many states, including Illinois, have adopted that guidance at the state level. And what I'm going to present to you today is the Illinois interim guidance that's published September 17th, 2025. So I'll first touch on CDC community guidance. I should mention that the community guidance is different from healthcare guidance, I think in part because we're talking about different types of risks on a population level. Obviously, with healthcare personnel, there are potentially more vulnerable contacts when it comes to isolation and return to work. Also, I think there's certainly a lot of attention paid to just feasibility in terms of communicating these types of guidances and what makes sense and what can be easily followed. So for CDC community guidance, straight off of the web page that you can see the screenshot on top, and I have the link on the bottom, it states that when you may have a respiratory viral infection, stay home and away from others, including people you live with who are not sick. You can go back to your normal activities when, for at least 24 hours, both are true. Your symptoms are getting better overall, and you have not had a fever and are not using fever-reducing medications. When you go back to your normal activities, take added precautions over the next 5 days, such as taking steps for cleaner air, practicing good hygiene, and then importantly here, wearing a well-fitted mask, as well as physical distancing or testing for times when you'll be around other people. So for most people, that masking is going to be the one thing that'll stand out and is something that is recommended by CDC. CDC's guidance does provide several examples of how people would apply this based on their own constellation of symptoms and fever, but this is kind of a standard example on their website. So going from left to right, if somebody starts having symptoms and a fever, they wait until they get to that middle flag, which is fever ends without the use of fever-reducing medicines and symptoms are getting better. And that needs to be, they need to be fever-free for that 24-hour period. If both of those things are true with fever resolving and symptoms getting better, then the person can go back to normal activities with those added precautions that include the masking for an additional 5 days. Moving on to healthcare personnel. So this is now the interim healthcare personnel guidance. You can see the screenshot in the upper right. This was distributed electronically by Illinois Department of Public Health through Siren and other mechanisms. And I do have the link posted on the bottom right there. To highlight, so this is healthcare personnel with mild to moderate acute respiratory illness, ARI, regardless of whether testing is performed, and who are not moderately to severely immunocompromised. They should not return to work until at least 3 days have passed since symptom onset, and at least 24 hours have passed with no fever without the use of fever-reducing medicines. Symptoms are improving, and they feel well enough to return to work. And just moving on to the next yellow highlight, when they do return to work, wear a face mask for source control in all areas of the healthcare facility, including all patient care and common areas of the facility, such as break rooms, cafeteria, and hallways, for at least 7 days after symptom onset or positive test, if asymptomatic, if not already wearing a face mask as a part of universal source control masking. Importantly, I didn't point this out yet, but you can see that double asterisk in terms of symptom onset. Symptom onset is defined as day 0. So when we talk about 3 days, that would be day 0 is symptom onset, a minimum of 3 days out of work, day 1, 2, and 3. And the first possible day to return to work is day 4. So that's kind of illustrated at the bottom of this screenshot. Just additional guidance. So sometimes people do ask the question, I'm not sick, but I've been exposed to somebody who's sick. What do I do? PHACT did provide guidance that was voted on, again, not formally adopted by CDC yet, and it's explained here. So healthcare personnel who have an exposure to influenza, SARS-CoV-2, or other viral acute respiratory illness, and who are asymptomatic should wear a source control device, such as surgical mask or N95 respirator, from the day of first exposure through day 5, 5th day after last exposure. And importantly, work restrictions are not usually necessary. And then the middle bullet is important. If any signs or symptoms of illness do develop, then they need to go to the prior slide with the guidance for people who are ill. Now, I do want to show you an example from my institution of how we implemented the return to work guidance. I want to emphasize, and I put this at the bottom, that this is, first of all, it's draft institution-specific guidance. And so this may change over time. We're going to implement this probably about a month from now, but there's still some discussion about this. And what I'm showing you here should not be construed as guidance endorsed by CDC or Illinois Department of Public Health. This is what we are doing at my institution, at least in draft form. So you can see here that for respiratory illness, we have divided up into 2 rows different categories of respiratory illness. So the first row is systemic viral respiratory illness, otherwise known as influenza-like illness. And we define this as fever greater than or equal to 100.4 degrees Fahrenheit, or feeling feverish or feeling chilled regardless of temperature, and new respiratory symptoms such as cough, sore throat, nasal congestion, or shortness of breath, and possible other systemic symptoms such as muscle aches, headache, fatigue, or malaise. If the healthcare personnel meet this criteria, then the middle column talks about they must isolate, and then this is the return to work criteria. They must be fever-free for at least 24 hours without a fever-reducing medications, symptoms improving or return to baseline, feeling well enough to work, and at least 3 days passed since day of symptom onset or first positive test, whatever is first, or day 0 equals symptom onset or positive test result. So this is very much just like what you heard in terms of that Illinois interim guidance. And then the masking requirement, same as Illinois' guidance, to say that they must wear a facility-issued face mask at all times while on site from day of return to work through day 7. The next row, mild respiratory illness, viral respiratory illness, will be defined as nasal congestion, runny nose, or sore throat, but no fever or other systemic symptoms. In this case, healthcare personnel may continue to work on site wearing a facility-issued face mask, and if symptoms progress or systemic symptoms develop, healthcare personnel should remain out of work and follow the systemic viral illness criteria in row 1. And the healthcare personnel must wear a facility-issued face mask until symptoms improve or through day 7, whichever is longer. And the very bottom just talks about if you have a positive test for influenza, SARS-CoV-2, RSV, or any other positive test, even if it's asymptomatic, to refer to row 1. So in summary, the isolation guidance is based on epidemiologic studies estimating the duration of transmissibility, mostly influenza and COVID-19 illness. Isolation guidelines differ for community versus healthcare personnel. Both guidelines rely on defining an isolation period and a period of face mask use, otherwise known as source control, to prevent transmission. People do need to feel better with symptoms improved and fever-free, and the key time points as a summary are for the community, 24 hours fever-free plus 5 days of masking, and for healthcare personnel, 3 days minimum isolation plus masking through day 7. And I'll stop there now for any questions. Thank you.
Thank you, Dr. Lin. And I'm going to just do the last few housekeeping slides. So I'm going to start just sharing the last few slides for housekeeping, and then we can go into Q&A. Let's see, current slide. Oops. Apologies. All right, so just to have people aware, there are a couple of additional resources for how to get fit tested that are sponsored through partnerships with federal grants and IDPH, including the one in partnership with SIMPAR to get healthcare providers fit tested. There is also, we have a partnership with the University of Illinois where they have developed a boot camp for healthcare professionals, especially long-term care facilities, where they will get training and in how to deal with combating respiratory disease in long-term care facilities. And I think finally, we have our regional infection prevention team led by Dr. Spencer, and they can also help local health departments as well as facilities, healthcare facilities, mostly focused on long-term care, but also dialysis centers or acute care facilities that need assistance in their infection prevention assessments and work there. So all these are resources available. And so just remind you, the key takeaway, please make sure that we think about vaccines, and not just vaccines, but non-pharmacological interventions, NPIs, to keep people safe in the community. Please take advantage of all the data resources as well as others in our guidance that Dr. Lynn and Don and I have shared with you, and make sure you know how to get in touch with your local health departments when you start experiencing outbreaks or a surge or a cluster of cases in your communities. And next to come, we will have our next holiday themed thinking about travel and foodborne related illnesses in November. We're very likely going to take a holiday break for December, but if not, if we do decide to host a session, we'll let you all know. Registration links are available there. You can reach out to us directly, to our clinicians in the medical service division. Please make sure you sign up for Siren so you get notifications of when we update our guidance, when we want to inform people about information regarding our outbreaks, etc. And with that, I think I just want to say thank you all for every single one of you for what you do, and we'll open it up for questions. I put this link for the CME in the chat, so you can also scan this QR code. I'll leave it on for about the next few seconds if you prefer scanning the QR code, but the link is also in the chat. This will also be available. Just make sure you do it before October 23rd. And I'm going to stop sharing screen and open it up for live questions. We have a few. We're already past the hour, so I appreciate all those who stayed on. One clarification, I just had a typo, and when I was answering a question in the chat, I meant to say if a healthcare facility, if a long-term care is not a healthcare facility, they still have the option of following the guidance Dr. Lynn said, that it's just not an expectation or requirement. So even if they're not, this is the bar, not the ceiling for how you should be thinking about infection prevention. All right, there is a question in chat. Okay, it looks like that's already been answered. Okay, there's one for Dr. Lynn. Are the facility issued face mask, N95 masks, or are surgical masks sufficient pertaining to return to work guidelines?
Okay, thank you for the question. So I think it's getting at just for source control purposes, are facility issued face masks sufficient? They are. So based on the data that we've seen, face masking with surgical or procedure masks are able to prevent transmission from someone who's sick, who's wearing that mask, to someone who's susceptible. So that is a hallmark of this type of isolation guidance. And it also is a hallmark of what many healthcare facilities are doing during the wintertime, which is universal face masking to try to prevent transmission.
Thank you. I think there is another question about whether it's official. I cannot tell, was that in the chat? Or please try to put your questions in the Q&A instead of the chat if you don't mind, so we can keep it organized. Is it now official that healthcare workers are required to stay home for 3 days instead of 5 following an illness? Yes, so that's the IDPH guidance. We are in the process of changing the hospital, the codes or the regulatory codes, but that is the current guidance that has been issued by IDPH. They now mask for 7 days instead of 5. I think, Dr. Lin, if you wish to, you can clarify this part too, because it's a total of 7 days of protection at a minimum, if you want to clarify that.
Sure. Yeah, I'm not sure about the 5 days where that came from. You may be referring to, I think, during the emergency period for the COVID-19 pandemic, that isolation was, in some cases, allowed at 5 days instead of 10 days. But I'm not sure if I recall any other masking guidance that included 5 days. But the idea here is that the masking does allow for protection in case there's still some viral shedding, even beyond when people feel well enough to go back to work and are recovered. And it does apply to all respiratory viruses. What Illinois Department of Public Health posted for interim guidance applies to all viruses, whether they're confirmed as flu or COVID or unconfirmed, untested at all. So you can do all this guidance based on just symptoms without testing.
And Dr. Lin, could you also clarify that how we see it as almost like the 3+4? So isolation for 3 days and additional masking for an additional 4 days. So the 7 days includes the 3 days of isolation, and that's again the minimum, not the.
That's right. Yeah. So it's a combination, right? It's a combination of isolation and masking, and you have to at least do both through day 7, actually sequentially, I guess. And beyond that, it just depends on when you meet the criteria to return to work. But everything is a minimum of 3 and a minimum of 7.
We have one more question, and I appreciate all our panelists for staying on. Oh, it was just someone saying thank you. So we appreciate it. Any other questions, or if not, again.
Dr. Barnes, I do see one question that says, can you confirm if healthcare workers are required to get the influenza vaccine? Is there a declination that's acceptable?
So there's no requirement, but the only thing in Illinois law is for employers to offer the influenza vaccination. However, you might have individual policies of your healthcare facility that are distinct from what's in the law. Sometimes if your facility is joint commission accredited, they may have a higher threshold for what they expect their employees. So it is important for the employers to offer, but there's no requirement to getting it. Any other questions? School administrators, yes, there will be a boot camp for school administrators. We have multiple engagement sessions around this issue. 3, for the exclusion is challenging for staffing of smaller offices. Any guidance? This is a tough one. 3-day exclusion is.
Sure, I think there's still always going to be some stress with trying to enforce isolation, and everyone's trying to do their best. I would just say that at least the way we've operationalized it at my institution, we are really trying to target those folks that have influenza-like illness. So if someone comes in with an isolated runny nose or just allergic symptoms, and quote unquote allergic symptoms, we don't know if it's a cold or if it's allergy. I think those are situations where we are allowing masking. And so hopefully that does help to mitigate some of the issues related to just workforce.
There is one about in the LTC facility, if a resident is COVID positive, they stay in their room for 10 total days. Is this guidance still accurate? So yes, the resident guidance hasn't changed. This are resident and inpatient. This applies to healthcare workers. And I don't know, Dr. Lin, if there are any differences in practice at Rush.
No, so we haven't changed for patients. We have not changed our isolation guidance. So that's a good point. I think there's a lot of interest in trying to update that, but I don't know of any current guidance being worked on. It would be welcome, I think, because I know it's a big burden.
There's a question, does a 3-day criteria stay in effect with a positive COVID test, or is it 10 days? So Dr. Linton, if you want to explain that.
Oh, sure. So for a positive test, the interim guidance for IDPH does recommend isolation for a positive test. That would be consistent with PHACT's recommendation as well. I do recognize that it is a little bit funny to sometimes have people who are asymptomatic, exposed, and not tested continue to work, whereas someone decides to test themselves, are positive and asymptomatic, they have to stay home. So there's some internal conflict there, and that I think I don't know if we can avoid it, but I recognize that that's potentially an issue.
All right. I think the questions around, again, moving away from the 10 days of COVID to just thinking about COVID, flu, and RSV and respiratory viruses or acute respiratory illness. And that's within that same framework, that unified framework that Dr. Lin had expressed. The question is, who has to offer flu vaccine? I will try to find the law. So it's only those who, I believe, who qualify as healthcare facilities. Not all assisted livings have official healthcare facility designation. In fact, they may have only some small spaces that are considered a healthcare setting. And there is, we'll see if we can find the legislative language, but you could also look it up in terms of what the legal requirements are for Illinois for offering it. All right. Any other questions? I know, again, I appreciate our panelists for staying online. Duration of isolation for influenza and RSV for residents or inpatients. Again, nothing has changed for residents and inpatients. We are in the process of also updating the IDPH guidance for that, and that will be issued shortly if it hasn't already come out. And that will include what they call transmission-based precautions and isolation guidance for residents for flu and RSV, which is not as long as COVID. They don't have to stay in, provided they meet other criteria. They're fever-free for 24 hours. The symptoms are dramatically improving, and they, have sometimes they don't have any other conditions like severe immunosuppression that may put them at risk for like a prolonged infectious state. Okay. All right. I think with that, I just want to say thank you, everyone, for spending your lunch hour with us, and appreciate all your patience. And stay tuned. You will get a copy of the master slide deck too. Take care. Bye.
Bye-bye.